Yes, Ankur, all over to you.
Yeah, thank you. And if you can see my slide, and I'll quickly wrap. Next slide, please.
Yeah, we can see your slides.
Yeah, next slide, please. So it was the Angelina Jolie effect, gene effect, which has made us wiser in last decade or so. And initially, these genes were just studied in textbook, and now we are routinely, probably, I'll say the BRCA1, 2 genes are being done in almost all the patients of ovarian, triple negative breast, pancreatic, and prostate cancer. And now we are wiser, moving towards HRD. What is this HRD, and what is this tissue BRCA, somatic, germline? So we are very wiser with all these tests. Next slide. Next slide, please. I think there's a problem from the organizer. Next slide. So Dr. Kumardeep, can you...
I think there is a glitch from Ankur's side. Ankur, you're muted.
Here, I'm there. So Dr. Kumardeep, if you can you tell the audience what type of BRCA mutation, the germline, somatic, the tissue BRCA, and what does exactly, in just a brief, what does all these mutation means to us, to all oncologists? Dr. Kumardeep.
Yes, when the concept of the BRCA came in India, so we had initially started with the blood sample. It is germline BRCA testing, and then tissue testing for the ovarian cancer only, limited to that only. And till a couple of months ago, we are practicing that. Nowadays, the newer BRCA is the HRD testing. So we have moved from the BRCA testing to HRD testing. So in tumor tissue, when we do the blood sample testing for the germline BRCA testing, we miss another 15 to 20% of the BRCA, which has been tested positive in the tumor tissue samples. So that's why the concept of tumor BRCA was also, somatic BRCA was also important. But nowadays, beyond BRCA, we are testing for the genomic scars on the HRD testing.
Yes, very rightly said. So we started with something in blood which was called as germline BRCA. So it is an inherited mutation which can be detected in blood and saliva. The patient may or may not have a somaticness or a tumorness. So somatic BRCA mutation is when the BRCA mutation, de novo somatic mutations, are detected in the patient tumor, which is known not to carry a germline or an inherited mutation. And the tissue BRCA mutation is which is detected in the sample, which is either an ovarian or a breast or a pancreatic one. And these mutations may be or may not be germline or somatic in nature. And non-BRCA, we know, where those who do not carry these mutations. So these term lines are very important, particularly when we are deciding the Paola 1 study, because they have included all these patients apart from the Solo 1 trial. Next slide. So I just quickly go with the classical case of ovarian cancer, a 52-year-old ovarian female patient, a female with abdominal distension and pain, CA125 high, good performance status, no family history or personal history, high-grade serous ovarian carcinoma, 4B to started with, given 3 cycles neoadjuvant paclitaxel and carboplatin, underwent a good debulking surgery, with Dr. Seko emphasized, no residual disease. So Dr. Rajat, what will be your adjuvant chemotherapy and a maintenance treatment as to start with? We do not have any evidence of BRCA-ness with us. Dr. Rajat Channa.
Yeah, hi, good evening. So I'll start this patient from cycle 2 onwards. I would like to start this patient on the same chemo regimen, and I would like to add bevacizumab from cycle 2 onwards. And regarding the maintenance, I'll continue with maintenance BEV, and would like to know the status of BRCA before adding any PARP inhibitors, because the only drug that is approved is olaparib in first line setting. So I would like to know the status of BRCA.
So very rightly said that he would like to continue the same paclitaxel and carboplatin, which the patient responded, and from fifth cycle or the second cycle in an adjuvant setting, a bevacizumab maintenance. The reason behind is that a 4B disease, a GOG, and ICON 7 trial, which clearly emphasized that high-risk patients adding bevacizumab may give a PFS and may give some overall survival trend. So as Rajat rightly said, he would certainly like to go for a maintenance treatment and certainly like to know the gene mutation, the BRCA-ness in this patient. Next slide. So Dr. Nagendra, so at this point of time, as Rajat and Dr. Kumardeep Datta emphasize, do you want to consider genetic testing? At this point of time, I would respond, yes, we would like to do genetic testing for all our ovarian patients. But at this point of time in 2021, what tests you recommend? You are happy with BRCA1, BRCA2, you are happy with germline, or you do a reflex testing, or you want to do an HRD testing if given all the opportunities? Dr. Nagendra, it's a big question. I want a good 5 minutes on that. Dr. Nagendra.
Right. So that's a very important question right now, sir, which have changed the paradigm shift, which have caused a paradigm shift in ovary cancer management. So as far as genetic testing is concerned, it is of paramount importance, and we have to assess this on individual basis, where you are practicing, whether you are practicing in a government setting, whether you are practicing in a private setting. If affordability is not an issue, I will be happy to use HRD testing by standardized lab. What by mean of standardized lab, what I mean is Myriad will be my first choice, if the patient is not affordable, then second choice will be like Foundation 1, which also is costly, but second in order of priority will be Foundation 1. Third, if the patient is still not affordable, third in order of my priority will be the somatic BRCA, like tumor BRCA I will be happy to use, in which like germline and BRCA, germline and somatic both will be positive if germline is not yet done. So tumor BRCA means you can have somatic and germline both. You have to do additional tests to figure it out what exactly you are having. And if the patient last will be the germline. So in order of, if you ask me, the genetic based testing, if you want to do, Myriad my choice, HRD testing, second Foundation, if Myriad choice is not feasible practically, third tumor BRCA or also somatic we should consider, and fourth will be germline. Why I have put Myriad first is like in the genomic instability, that large scale states transition is a part of Myriad, but large scale states transition is not a part of Foundation 1. So that's why Myriad will be my best choice if affordability and logistics is not a concern. Otherwise, Foundation 1, HRD testing, and third, as I told, so this will be in order of priority. Without doing HRD, it is not ethical to start treatment. But if you are working in a resource limited setting, then you can consider for fragmented tests like germline or somatic. We know that if you do only germline testing, you will miss a substantial number of somatic mutation. So, and HRD and HRR, they are not interchangeable. You have to have, one is cause, one is effect. We should be very much clear about the basics, and then we have to take call accordingly.
So very rightly said, and Dr. Nagendra has opened a big Pandora box with mentioning word like his dreamline pathway 1, 2, 3, 4, Myriad, Foundation, the somatic, and the germline, and clearly is mentioning that the need of R is to identify these patients who are beyond BRCA1, BRCA2, and as we see, as Sushant also showed these slides, so the actionable mutation, if we test only germline settings, so we find that 15 to 20% of our patients carry these BRCA mutation in ovarian cancer. But if we actually go for some other genes, the HRR gene mutation, the altered gene, basically the BRCA-like gene in the same genomic loci, so then we can able to test these patients, and approximately 50% of these high-grade epithelial ovarian cancer have HRD, and now we have the literature in the form of Paula 1 that these HRD harboring a high-grade epithelial ovarian cancer responding to this PARS inhibitor and giving that substantial benefit in the PFS and possibly in the OS. So when these HRD is being tested, and certainly as Dr. Nagendra said, this is need of an hour. But Dr. Mudassar, please tell me I mean, is this dream testing is ever been done at the ground level? If all the patients, are we actually able to do these HRD testing, and how many of these patients understand these tests, and how many actually do these tests, and how many oncologists or in the Monday morning practice, what is the percentage, what is the ground reality when it comes to HRD? Dr. Mudassir, please.
Sir, I completely agree with Dr. Nagendra. He actually gave a very idea. In an ideal world, I would do HRD in every patient. And to begin with, I can just tell them that please do the HRD and then come to my OPD. But we live in the real world, and we have actually so many difficulties in doing HRD. We know the biggest difficulty being the cost of the ideal HRD, that is the my choice. So what I would do is that I do the BRCA 1 and 2 mutation testing first, either germline or somatic, whatever is feasible at that time. Obviously, one after the other if I still have doubt, or if it is negative. But and do the HRD only if they are negative, because that way I can actually I can actually take all those patients where I can do it at a very fraction of the cost. So, and then later on do HRD and only those patients where it is not present, where I do not detect any mutation. So this way, this is a cost sensitive kind of probably a way of doing it. And the other thing is, yes, I can agree with all the points of Dr. Nagendra that HRD is important. Whatever this HRD comes from, whether it is BRCA, HRR, whatever is there, the end result is HRD. That is important.
So very rightly said. If Dr. Vineet is still on board, and Dr. Vineet, what is your take on this? If you can very candidly answer this question. So do you emphasize on HRD when it comes to an adjuvant setting parallelly, or you before giving paclitaxel, carboplatin, or bevacizumab, you say that it can be done parallelly and you give time to the family and the patient, or you emphasize to do this test first, then I will be proceeding with the treatment? Dr. Vineet.
Well, there are three components to that. First is the pre-test counseling, which we never discuss in our discussions. That is very, very important. And only after you have gone through the gamut of pre-test counseling, then of course it should be done at the inception. And I think the guidelines also support that. And as Nagendra and Mudassir have told, if possible, then you do the HRD testing, the whole panel, instead of just doing the somatic or germline BRCA mutations.
Yeah, so very rightly said that pre-test counseling, making the relatives, making the patient understand in that layman language what is that HRD testing, what impact does it have, and we have discussed about the reflex testing, which both of the previous speakers have said that Mudassir told very candidly that go for a germline test, which is easy. If negative, go for a somatic, and then go for an HRD testing, which is costly, and the patient and the party may understand what is the importance. But yes, as Nagendra said, he would like to go for an upfront HRD scar testing, which would take out the maximum population, which is at present 50% of the patient. As per many trials, that we will be able to pick those 50% of the patient, and those patients will benefit from the PARP inhibitor with or without bevacizumab later on. Next slide, please. Next slide. So I'll think we'll come straight away to the questions. Next slide. Keep on going, Palak. Next slide, please. Yes. So we have discussed. So Dr. Kumardev, so do you agree with this reflex testing, first germline, then somatic, and then HRD, or you want to emphasize HRD upfront and go that way, as Dr. Nagendra said? This is important to know.
Yeah, I usually start with HRD, because when you tell patient one test after another, they get frustrated. So. Okay. They get frustrated. It is my personal experience. They get frustrated. So upfront, you have to tell them that this is the test and this is the cost of this test. If you can't afford, then go for that test. Okay. Otherwise, one by one, if that is coming negative, that is coming positive, or whatever, I think a patient will get frustrated. It will be time consuming, and those who want to do, they will do upfront. Those who cannot afford, they will never do. Yes. So in my practice, I tell everybody 100% of the patients are counseled for HRD. Out of that, 50% don't understand the importance. In my practice, I'm not telling about Ankur, your Talwar sir's practice. In my setup, 50% they don't. It is like probably they don't understand the importance, and 50% understand. 30% they do whatever, all the testing, like including HRD, BRCA, and maybe 10% are doing HRD. The rest are doing germline or
So I
somatic.
think Dr. Kumardeep has been very honest to say that he explains everybody. 50% of them do not understand what is this test. And out of those 50%, maybe 20-30% may get this test by understanding the cost, the implication of the drug which will be offered. So yes, very important. So cost and the implication and the cost of olaparib or rucaparib must be made understandable to them with the side effect profile, and then these patients can turn up with the test and the benefit of this test. Next slide, please. Next slide, we have discussed all this. Next slide. So HRD testing is basically an NGS based test that sequence BRCA1, 2 and many thousands of loci across that genome. The gene regions are analyzed for the presence of pathogenic and likely pathogenic mutation, which we want to exploit and give PARP inhibitors for them. The genome-wide data is used to compute a genomic scar score, which is the measure of that instability. And the sequence is carried out usually on Illumina Next sequence platform. So the threshold of the scar is used to define positive or negative. And Dr. Vamsi clearly said that 50% is the score, which we say that it is negative or positive. Next slide. So GIS, genomic instability status, is indicated either as low or high, and the GSS is a numerical measure of that instability, which is 50% in most of the tests. And so there are certain instances that could a patient of tumor BRCA or germline BRCA may have a low GIS or vice versa. Yes, most patients who carry this germline or tumor BRCA mutation have a high score, but there is still a possibility that a low score can be achieved, probably if the total number of loci across that genomes are less in number. Next slide. Could a patient of VUS in either BRCA or 1, 2 can have a high GSS? Yes, the answer is yes, even in the presence of a specific VUS in BRCA 1 or 2, but still you can have other genes which can give you a high score. Next slide. So Dr. Rajat, what would be the ideal sample to be sent for an HRD testing? What do you prefer? You get the blocks, previous blocks, a new fresh biopsy if it is a recurrent disease. So Dr. Rajat, your thoughts on that?
So I think you have shown the slide, sir. So it should be FFPE less than 1 year, and the DNA content should be around 20 to 30.
Yeah. So though it should be a fresh frozen, if possible. The block should contain more than 30% of the viable tumor, which amounts to 100 nanogram of the DNA, and it should be a pretty young block, less than 1 year old. And if you are treating a long PFS, 2 years, 3 years, so you should get ideally a new block, new biopsy, and we can send for HRD sampling. It's not done on blood and saliva because the fundamental is that it can have a very trace amount of tumor-derived DNA, so you cannot get those ideal setting and ideal score on that. Next slide. So if so, Dr. Kumar, we'll go to Dr. Nagendra. So Dr. Nagendra, this patient is BRCA mutation positive. You take it either way, myriad score high, foundation, the germline, or a somatic, your choice. So what will be your current preferred first line medical management of this patient who has underwent 3 cycles of neoadjuvant chemotherapy, stage 4B, followed by R0 resection, and the patient is yours with a tumor BRCA mutation positive? Dr. Nagendra.
Right. So as the sir have already told in the previous presentation, that the SOLO-1 trial was the maintenance trial in which we have seen that olaparib is the viable option in a BRCA mutation positive patient. And we have seen many trials, but we have never seen any trial in which there is quadrupling of median PFS. As you can see in SOLO-1 trial, the median PFS was 56 months, vis-a-vis 13.8 months with hazard ratio of 0.33. So there is no trial in ovarian cancer management which have shown a quadrupling of median PFS, isn't it? So this will be my viable option. Olaparib will be my treatment of choice in the patient who are having a BRCA mutation positive in a maintenance setting. And carefully, we have to tell everything. We have to document clearly that olaparib can cause some secondary malignant neoplasm in form of MDS or AML. That also have to be clearly written in the record so that it should be medically documented. So my choice in this type of scenario will be olaparib, sir.
Yes, so this is the summary of approved maintenance studies in the first line, the solo one, the Paula one, the Prima, the niraparib study, and we have previously experienced bevacizumab maintenance as per GOG 218. So solo clearly showing that those patients who are BRCA mutated, they do 4 to 5 times better, 56% versus 56 months versus 13.8. So that was clearly showing. And to emphasize your comments, Nagendra, that Paula 1. So if you are going for an HRD testing, the BRCA wild type still HRD positive, and so BRCA mutated, HRD positive, and BRCA unmutated and HRD positive clearly shows that with the addition of PARP inhibitors, we get a survival benefit. Yes, there are some side effects because of this PARP inhibitors, the fatigue, anemia. So but we have learned how to reduce the dosages, how to get rid of those anemia. So Solo 1 and Paula 1 clearly showed that if a maintenance PARP inhibitor is added to this kind of patients, which can be 50% of our cohort, so 50% benefit will be given to these patients in terms of survival. Next slide. So I can ask Dr. Kumardeep again. So if the patient does not have BRCA mutation and is HRD is negative, so Dr. Kumardeep, how do you judiciously use bevacizumab in such patients? Dr. Kumardeep? So I think Dr. Mudassir can take this question. So Dr. Mudassir, if patient is BRCA wild type and even HRD is not being done or negative, so the poor man's meat, bevacizumab, how do you judiciously use in the first line maintenance, Dr. Mudassir?
I think from the bevacizumab point of view, the bevacizumab has been seen that it is beneficial only for those patients, with stage 3 or stage 4 ascites, pleural effusion, or extra abdominal disease. Those patients will get benefit from bevacizumab. I think there's a separate discussion from the olaparib, or whether we have to give olaparib or not, or PARP inhibitor or not. That's a separate discussion. But regarding the bevacizumab, I think I would suggest, and I will counsel the patient regarding the bevacizumab maintenance if the patient is having stage 3 or stage 4 ovarian cancer.
Yes. So I think we have lost the slide. So rightly said, in GOG 218 and in ICON 7, the subset analysis clearly said that if patient has a higher risk disease in the form of good amount of pleural effusion, extra abdominal disease, and lots of ascites, so those were the patient who got benefited from bevacizumab maintenance as compared to. So Dr. Vineet Talwar has asked a question. So Dr. Rajat, if you can answer this. So how to compare PARP inhibitors and bevacizumab in this situation, particularly niraparib or olaparib? So if we have a tricky situation, and so how to actually compare this niraparib and bevacizumab in such patients, or PARP inhibitors or bevacizumab in such patients?
So,
Dr. Rajat.
I don't think there is nobody knows the correct answer, because it's still an ongoing process. So I think that if it is possible, then in HRD positive patients, stage 3, 4, then combination of PARP plus bevacizumab should be the way forward. And because we are comfortable with using bevacizumab, and we know that in stage 3, 4 patient, it does help at least in the PFS. And giving olaparib or other PARP inhibitors, they are not very comfortable drugs for the patient. So I would say that in stage 3, 4, then combination of PARP plus Bev should be preferred as compared to PARP alone.
Yeah.
Can I interject, Ankur?
Sure, please.
In an HRP setting, when you have BRCA wild and HRP, should you at all give PARP inhibitors? anybody can answer that question.
So I think the slides clearly shows that we are in. So the left hand slide is including tumor BRCA mutated, when you get an advantage of olaparib with bevacizumab versus a placebo with bevacizumab, and when you have BRCA unmutated and still HRD positive, the graphs are still splitting. So you get an advantage. So that is the message, that HRD testing, if you are able to do HRD testing, then 48 to 50% of these Paula patients were having HRD positivity. And then the olaparib or the PARP inhibitors gave that advantage irrespective of bevacizumab use. And those patients in which HRD was unknown, the PARP inhibitor did not give that survival. The HR ratio was 0.98. However, the HR ratio was 0.60 or 0.56, irrespective whether you are BRCA mutated or you are excluded BRCA mutated. So if you are able to get HRD positivity through these tests, the valid test, then you are giving that survival advantage, which was 35 versus 50 months or 30 versus 50 months in favor of PARP inhibitors. Next slide. Next slide, please.
Ankur, if I might add, primer
Yes,
trial showed that even in BRCA wild and HRP, there was a benefit of about, although it was a very slim benefit, it was about 7 to 9% benefit.
Yes, sir, clearly. So BRCA wild type and HRD positivity gives us that advantage of adding a PARP inhibitor, irrespective of BRCA-ness. Next slide. So this was what Mudassir was talking, that in bevacizumab this is not. So substantial PFS benefit in HRD positive tumors, irrespective of the stage, irrespective of the low risk or high risk, PARP inhibitors gave that advantage. Next slide. Next slide, please. So this is the standard systemic treatment, just 30 seconds on this slide. So testing somatic or germline, all ovarian cancer, tumor HRD testing, it should be told to the patient, and we all oncologists should know the advantage of HRD testing, which goes on to the survival benefit. So decision one, either a upfront surgery or a neoadjuvant surgery, give carboplatin, paclitaxel. So decision is how to maintain these patients either with bevacizumab, PARP inhibitors plus bevacizumab. So this HRD testing and germline testing will give that path. So if we have a HRD positive or BRCA mutation, solo 1 or Paula 1, if we are HRD positive, BRCA unmutated or mutated, yes, Paula 1. And if we are HRD negative, so then, as Dr. Vineet said, add PARP inhibitor or a clinical trial, or add bevacizumab if the patient has a high-risk disease in the form of stage 4B or stage 4A. So basically, the fundamental is how to maintain these patients, give them survival advantage with quality of life, with no side effects, and increase that first DFS, because we know that with PARP inhibitors, we have PFS2 things are also coming. So we have to use these drugs judiciously and these tests judiciously so that our patients can get maximum survival.
There is one doubt from my side. So what will be the additional advantage of doing HRD testing in early stage ovarian cancer?
So Dr. Vineet, would you like to take this question? In early stage 1, 2, or even 3A, 3B, would you like to do HRD testing?
The funda is very simple. It is predictive and a prognostic value. So probably you can have a insight into the disease if you do it at inception, irrespective of the fact whether it is early or late ovarian cancer.
Yeah, so these trials, Solo 1 and Paula 1, the design of these trials were that the newly diagnosed advanced epithelial ovarian cancer were taken. But yes, Rajat question is rightly that whether would you like to extrapolate this stage 1 and stage 2 ovarian cancer for this HRD testing? We have to actually wait for the long randomized trials and good number of patients to solve this. But as Dr. Vineet said, it is predictive and prognostic both. So at least for all ovarian cancer, irrespective of stage, we should get a BRCA testing done. That is for that patient later on and for the family. So these questions, the usage of this PARP inhibitor in early ovarian cancer, we have to actually wait for some time to get a good answer for that. I think I hand over to the organizers. We are already running late. It's 8:45. So over to Dr. Vineet.
So there are a couple of questions in the chat box. If you can just quickly take care.
So how do you put olaparib and rucaparib as a choice of PARP-dependent tumors based on your experience with both the molecules? So Dr. Kumardeep, if you can answer this. Dr. Mudassir?
So in the first line, I don't think it's a choice with us. So as long as we don't have a data for that, it would not be possible for us to prescribe it. Though it always kind of, this question always is in my mind, that should we give rucaparib to those patients who can't afford the olaparib? I don't know about that. So, but till the data is not there, I don't think it should
so
be.
I think Dr. Sitakshi Joshi put a right question. So we've been using these molecules as per our convenience. They are the same inhibitors, but yes, rightly said by Mudassir, not being used at first line as per Solo 1 or Paula 1. So, but yes, the olaparib, rucaparib, niraparib have the same mechanism of action, but the short of those trials, whether we can use, so it depends upon patient to patient. If the patient understand the biology and the disease and the advantage, so I would say why not use this drug if it is cost effective.
Agreed, sir.
Yeah. So I think all the questions have been answered, Dr. Vineet, and over to you.
Yeah. Thank you. So this question which Mudassir asked, I would, be on a slightly different tangent. See, if everything goes fine, nobody says anything. The moment the morbidity comes, immediately, you get wise guys around and they start asking all kind of questions. And if you don't have a label, then you're stuck royal deep. So I think you will have to discuss in depth with them. Of course, we know that the mechanism of action is the same everywhere. It has to work. But then, their concurrence has to be there. Short of that, I don't think we should use it off label. So I think a very nice discussion. I have already made the summary. So I think we'll complete the session here. I hand over to the organizers.